Hello and welcome everyone to this Biopsy Masterclass or Biopsy Workshop. I want to thank you. This is something that I'm going to be doing shortly for the residents, and I always like to kind of make use of time in my practice when I'm doing something like this. So today we're going to do a deep dive into biopsies. I would encourage you, if you have any questions or comments, to please put them underneath this video, and then I can answer any of them. I'll send out an email afterwards for those of you that have registered for this with the answers to anyone's questions. It's kind of hard to do it while I'm doing it live here. Okay, so we can do that after. So I want to go over what we're going to be covering today. It's a lot of stuff. I hope to finish in about 40 minutes or so. And we're going to go over what are the indications for a biopsy, the most common pathology that I see in my office, my private practice numbers, biopsy types, uses, codes, and examples, the difference between incisional and excisional biopsies, practice management tips, scripts to talk to patients. For the medical record, I'm going to give you all of my macros, all of my consents, all of my instructions, all of my photo consents, and then any patient questions and doubts. So it's good for you to stick around because this is something that we're going to do here live, and people won't really get access afterwards unless they're part of Podiatry, the Practice Mastery Academy, where I'm going to put it there afterwards. Okay, so let's get into it. First of all, we're going to go over the indications for a biopsy. These are atypical appearing lesions. Okay, so these are things that look kind of weird. You don't see every day, you're not really sure, aren't getting better with traditional treatments, typically appearing lesions which behave in an atypical fashion. So for example, a patient with antifungal topically that's not responding like an antifungal should, or a steroid cream like it should, that's what would be a reason. Progressive, long-standing lesions or conditions which cannot be adequately explained. So those are some of them. So the most common one I do it for is a tinea pedis that's not resolving, or I'm not sure what's going on. Also, second would be a dermatitis, xerosis, eczema, something that I'm not really sure what it is, something even I may have treated with a steroid cream or an antifungal that's not getting better. Different types of skin lesions, and I'll show you some of those, skin discoloration, and then rashes. Those are the most common things that I do in the office. I don't have any real wild things. And I didn't put on here nails, but nail really isn't a biopsy. It's more of a nail sample. I don't consider that a biopsy. So just to give you an example, the first time I did this lecture, I think was 2018. And I pulled the data that I had. So from 2012 to 2018, I had like malignant melanoma here. Would be like a carcinoma, carcinoma in situ, kind of a unclear behavior of a soft tissue mass, and then a carcinoma. So a lot of carcinomas, a couple of malignant melanomas that I had to refer over. So these are in our practice, things that you're seeing and things that you're probably just saying, oh, let's see how it does. So first of all, let's talk about, this is my number one that I use. It is a CPT right here. You can see that. It's for a punch biopsy. You can use it for a number of things. You can use it for a vasculitis, an ulcer, if you're unsure if it's not getting better, a pigmented lesion, neoplasm, a verrucous lesion, looks like a wart, dermatitis, and tinea. These are the two most common things that I use it for. Why would you use it on an ulcer? Well, if the ulcer is not responding and you're concerned that it might be kind of a malignant transformation of that ulcer, you are certainly entitled to doing that. What are the benefits? Provide an evaluation of the dermis. I like this. This is my biggest thing. I do 2 millimeter punches. I do two 2 millimeter punches, and I'll give you my how I do that in the chart, and then use it to evaluate a smaller part of a larger lesion. This is what I tend to do. So you're not taking the whole thing out. So it's a big lesion. You're taking a part of that lesion out, and I use 2 millimeters versus a 3 or larger where you have to do a suture. So here's an example of a lesion. Here's an example where you would do a biopsy, go down, twist it. I usually go down straight, so I go straight, twist it, and then turn it to the side a little bit and push it a little bit so it'll pop out. Biggest frustration with this is the darn thing gets stuck in there. and you have to get it out. So when I am injecting the patient with lidocaine with epi, I do, I save that needle in case I need to kind of hollow it out and get that. Otherwise, you look kind of funny because sometimes you take the end, you try to blow in it and it looks kind of funny with the patient, or drop water in it, or saline or whatever, but you're putting it in formaldehyde. So tips, don't crush the specimen as you do it. So that specifically when you take it out, you try to get it out without injuring it. I tend to use a tissue nipper, get in there underneath it, get the tissue nipper and kind of remove it. I try not to grab it with a forceps. It has to go into formalin. It's full thickness. So it's epidermis, dermis, and subcutaneous. So you can see the fat. Most heal by secondary intention. And you can use a suture if it's over 3 millimeters, 3 to 4 millimeters, you might. That's why I like 2 millimeters with 2 different sections. Pigmented lesion, a larger biopsy can be used, and you can mark the location on the foot. So you take nowadays we take pictures. So you take a picture and you mark where it's at. It's like you can put a suture in it to say the one that's at the 12 o'clock position or whatever position. So taking a picture, sending that with it, very easy in your EMR. Take pictures, download it, send it to the pathology lab as an attachment, real easy to do, especially if you're concerned of a melanoma. So some examples here. This is kind of the fun part. What do you think this is? This is a patient that was treated for this on the top of the foot, was seen by multiple doctors for antifungal treatments. This came back as an eczema. So we used a very strong steroid. My most common favorite ones are like betamethasone, propionate, and so usually betamethasone is the most common one. A couple of other ones I like is like a fluconazide, I think it's called, and so really much the ultra high. Sorry if I'm butchering the name if you guys are dermatology people, but those are the most common ones that I use, or clobetasol is another one that I use. So this kind of got better with this. Another example of a patient right here. This wasn't mine. I got this probably on the internet somewhere. This came back as squamous cell carcinoma. So biopsying that. This was a patient of mine. I took I would do like a biopsy here and a biopsy here. Any ideas what this was? This was a carcinoma. Okay. Squamous cell carcinoma. Example right here. Biopsy. I took a biopsy right here of the patient. Any idea? Another carcinoma. And recently I just had another carcinoma on the top of the foot. Would take a biopsy right here and maybe right here, 2 different spots, bottom of the heel. Any thoughts? Another carcinoma. And this is one recently. So I took 2 little biopsy spots, 2 2-millimeter punches, and this is a basal cell carcinoma. Okay. And then this one here, dark lesion on the bottom of the heel. Thought it was just kind of dirty. I took two, and it came back as a melanoma. Then I referred this over to someone to excise that. I don't tend to excise these melanomas. I tend to send them out because they might need other things to be done. Example of another one. This is a bad one here. This is a dyshydrotic eczema. Similar thing right here. Patient probably with a nail procedure using an adhesive on the top of it. So contact dermatitis. This we see in our toenails because of the when we put band-aids around them. If you put band-aids directly on the skin. Another example: sides of the foot, back of the foot. What are you thinking? Right, Kaposi sarcoma. Okay, on the bottom. So once you can things you see. You don't want to miss these things. So next would be curettage. Curettage is a curette. I have these. I don't know if you have these in your clinic, but basically, mine doesn't look like this. It's not open. Mine's the closed one that I have in my treatment room. And so I just curette it out. It's less commonly used, in my opinion. You scrape the surface of the skin. I typically use it for erythrasma or tinea pedis between the toes. There's no anesthesia, so that's kind of the benefit. And it's a little difficult to evaluate the specimen for the pathologist. But for example, you can kind of take some of these things, these little flaky things off and send them, or you could just do a punch. Once again, flaky skin, you can take it off with a curette. This was tinea pedis. And here's another example here. You can take this flaky skin off, or you can do a punch biopsy. This was a patient that took a long time to heal, meaning to make this go away. And this was psoriasis. And the reason this took so long was because they weren't consistent at using the steroid cream. If they were consistent, so I do a couple of things. I may have them track it. I have them bring in their tube so I can make sure that they're using it, their tube of steroid cream. I will have them do it under occlusion, so having them put plastic wrap around their foot and then a sock on so it'll stay on longer. But I find just getting the patients to use it, it will work. And you know, if it's not working, it's because they're not using it. So that's the key for things like this. Between the toes, you can get your little Woods lamp. Those are really easy to do in the treatment room. You can see it's kind of, it's shining, and then you can take a little curette, and that would be erythromasma in there. And then for shave biopsies, I don't do many shaves, I want to be clear, but you can shave off a lesion, papule, macule. You can remove the whole lesion, usually larger than 1 centimeter in width, and it works well with elevated lesions. So we have elevated warts, but they're not going to shave off that well. But here's an example of one that you might want to, which would be lichen planus. Nail biopsy, this is something that I do, like maybe I do punch biopsy first, then I do curette, and then maybe nail biopsy. So I use it to evaluate dark discoloration of the nail beds. Once again, a reminder, this is not a nail sample. A nail sample is not considered a biopsy. Taking a nail sample to evaluate for fungus is not a biopsy. So this can be done with a simple digital block. I usually use a 3 millimeter punch, or I will do a tangential biopsy, and I'll show that to you in a second. But you can remove the nail and just do a shave. Okay, so let me show you. This is an example where you could do a punch. If you see it on the skin, you can do it further down here on the nail. This came back as a melanoma. Here's an example of how to do a tangential one. If you do it, you'd make a little incision on the base, you pull back the skin, and you take a little bit of the area at the base of the toenail. Right? So you take a shave biopsy, a real thin layer there at the base, and then you can suture things back down. It'll heal up pretty quick to verify that there's nothing there. So tangential is a really good way of doing this. If you haven't been, it'd be good for you to go to derm foot. That's where I learned a lot of these things that I use in the practice. I tend to do a punch. I like to do a punch biopsy. That's a little bit easier for me. And it might be a little bit larger. So instead of a 2 millimeter, I would tend to use a 3 millimeter punch, and I go right through the nail, and then I go into the nail bed. Example of one of my punch biopsies that I did. Okay. And then that heals in pretty well. Needle aspiration, probably the least common. Here are the codes with and without imaging, and all these have the codes. You can go back and look at the codes. Use it for like a lipoma or a ganglion, and you try to aspirate things. Let's say you try to aspirate for a ganglion and you can't get any of the liquid out of it. You can still send that. So you flush it out. You flush it out with the formaldehyde from one of the other containers. And you can evaluate deep masses as well with ultrasound. So you can look at the mass, you can try to aspirate it and see if you can get it out. If it's a ganglion, you'll be able to get it out. I don't send every ganglion. I want to be clear about that. I do not do that. But if there's something I'm unsure of what's going on in there, I'll send it. So you have to create back pressure. So you have to pull it out. So you need a big enough syringe to do that, like a 10 cc syringe and like an 18 gauge needle, 18 or 20 gauge needle. And you put it in different quadrants. And I do this with ultrasound guidance. And then once again, even if there's no tissue, you can send that specimen as well. Wanted to go over quickly some of the types of biopsies. This is normally in the hospital. When we're doing this, they always send this thing back. What did you do? Did you do an incisional or excisional? I want to explain the difference. An incisional is removing part of the larger lesion, and excisional removes the total lesion. So this would be an incisional, removing part of the lesion, and this would be an excisional, a punch excision, the whole thing, punch elliptical, or here is an incisional biopsy or punch. Okay, so you're doing part of a bigger lesion. Some practice management tips, because I do these quite a bit in the office, and I do them same day. I don't have patients come back. So you have to have the instruments in the treatment room. So I have 2 millimeter punches in every single treatment room, and little bags for nails, and have little bag and little formaldehyde little cups. Okay, I always ask, give me 1 cc of lido with epi, and my staff knows when I ask for that, they are going to prepare the consent for the biopsy. So they do that for me as well, and I tell them where it's at. And so I'll do that, and I'll usually numb it up with the 1 cc, and then usually literally 5 seconds later, it's ready with the epi. Even if it's in the toes, I'm okay doing it in the toes for the epi. I'm okay with that. I use 2 Band-Aids with gauze. So gauze, 2 Band-Aids, and I give them post-biopsy instructions, and I'll share those with you so you can make your own. I do the procedure codes. So I do 2 2 millimeter punches. I don't think this actual presentation has the procedure codes. I will make sure and include them with a link underneath here. I'll probably just pause and add it, and I'll show you guys. And then the 2-week follow-up, I do 2 weeks, And I also send a note to the referring doctor with the results. So they send, my pathology lab automatically sends the results to them. So practice management tips, talking to the patient. So I usually do this after trying initial treatment without success. Not everyone that has tinea is getting a biopsy. I want to be clear about that. But every patient that comes in for a second opinion or has had treatment gets a biopsy. So if they've tried stuff for tinea pedis, it's not getting better, or eczema, it's not getting better, I will do a biopsy. I advise them it's the best way to verify what you have. I specifically don't make a big deal out of it because it's not a big deal. I just numb up under the skin, takes me 5 seconds, and then I take a little punch and I put a Band-Aid on it. I say, Mrs. Jones, I'm not sure what you have in your skin, but it would be best to determine what this is before starting treatment. I can easily take a skin sample today that will help us determine what you have and we can start treatment. How does that sound? I've never had anyone say no. I did one and I found a basal cell on a patient recently that was 90 years old. So even though they're old, I still do these on older patients. Okay, so those are my tips. Here are my, these are my macros. So macros are what's in my EMR. So this is what I call them, like the biopsy follow-up, nail biopsy review. So you can look at these later. I'm not going to read these to you, but these go in my discussion notes and my physical exam notes. And then I talk about tinea for possible tinea pedis, recommend a biopsy. He had a lesion which is of concern. I'm going to biopsy it, biopsy of the nail, and then the follow-up visit, biopsy to the blank is stable. So these are my templates. You can add these to yours if you want for it. Here's my consent. Basically, I authorize Dr. Pelto to do a biopsy, infection, pain, and this is an example of a consent. You can go back and pause this video to look at that as well. Here's my home care instructions after a skin biopsy, right here. Okay, you can kind of see that. You can steal those if you want. And here's my photo consent. Many times I'm taking a photo, and this is only if I'm using it for like marketing or something else like that. And many times I'm not even, because there's no patient identifiers, no one's going to really know what it is, but this is my consent form if you want for a photo. Before I go on to these, give me 1 second. I'm going to show you the actual procedures in my EMR. Okay, I'm back here. Let me go over a little bit more of this. So these are the procedures. So this is a skin biopsy, single lesion, and it says, talks about this. You can read this. The procedure was performed on the blank, because you can fill this stuff in. And then here's the different sizes of the punch. You could do 2, 3, 4, 5, whatever you use. This is the additional. So when I do 2 of them, I do this one and the previous one. I did both of them in my EMR. Same thing, pretty much repeated. Example of a nail biopsy. I've just filled this in so you can see what it's like. It has right, left, and then what areas of the foot. You can add those into your EMR. Here's a punch of the nail biopsy as well. This is kind of an example of it as well. Here's a curette. What area, this is all the same stuff, right, left, and then what area of the foot you do. And then a shave biopsy example right here. You can look at this and copy it. And then I wanted to go over some common questions that patients have for me and how I answer them. So basically, can't you just tell by looking at it? And I say, I don't know, same thing with nail fungus. I can't really tell, especially if you've had treatment. I can't tell just by looking at it. I have a good guess, but I've been wrong many times. And so I think it's just quicker to get a biopsy. If they're concerned, I can certainly start some things like I do, but if it's not getting better, I do a biopsy. That's what I do. Can we try something else first? Yes. So if they haven't tried anything, I might do a topical antifungal. Normally I start with a topical steroid versus a fungus versus a fungal, because normally it's a steroid issue. They need it and they have to be consistent. The best way to get patients to be consistent, I learned this in derm foot, was to have them come back more frequently and have them bring the bottle with them to make sure that they're actually doing it. Do you think I have cancer? I never answer that. I say, no, I don't think, but I'm just kind of verifying what it is. And normally it isn't cancer. And isn't a thick nail always fungus? Said, no, a lot of times it can be from trauma to the top of the nail, things like that. So here's some resources. If you want to download this presentation, take your phone and you can scan this with a QR code scanner. You can get access to the Google Slides. There are a couple of benefits to doing that. You get access to the slides, you get access to my templates, And you can get any updates because I may update this slide deck based on feedback I get. Please give me feedback. You can either type it underneath here if you're watching this, or if you're watching a recording, you can type it or send me an email. I'd prefer that. Don@podiatrypracticemastery.com. Anything that kind of you do that's different than this, anything that you would like to see, any other things about biopsies or any other conditions you'd like to see, or just your feedback, I'd love that. That's my email for this practice management stuff. Once again, hope you guys found this beneficial. Hope you have a good one. Okay, appreciate your time. Thanks. Oh, I should mention something before that. I do have my patient presentations tool. If you guys have seen that before, that's kind of my go-to for all of my things for my business. So let me share that with you guys quick so you can take a look at this. This is like my favorite thing within Podiatry Practice Mastery. So this is it. If you guys haven't got this, go to patientpresentations.com and you can get it. Basically, this is my link tree for everything that I treat. And this is what I use for every patient in every treatment room all day long. So it's basically all my slide decks. To get that, you can go to podiatrypracticemastery.com and you can get access to all of this. This is this free tool right here. So all you have to do is put your email in here. And then the other thing that I have, a lot of my patients like, it's the course, it's this Practice Mastery Academy. This is all my resources, all my webinars, all the patient presentation tools, and then also the 30-day practice blueprint. If you guys haven't got that, this is how you can get this, just by clicking this link. So these are things I'd like you to do afterwards if you want to learn more, if you find this beneficial. If you're watching this now and you don't remember where it's at, everything's going to be inside of the Practice Mastery Academy in the future. This live event initially is just for those that are watching it live. Otherwise, afterwards, I'm going to put it there. It's not going to be on YouTube forever. Okay. Thanks, guys. It's been fun.